Welcome to Pediatric Case Review, Musculoskeletal Series. Today's lecture is a comprehensive case-based review of osteosarcoma in children, the most common primary malignant bone tumor in the pediatric age group. This lecture covers 13 carefully constructed clinical cases spanning pathophysiology, clinical presentation, physical examination findings, imaging interpretation, laboratory biomarkers, biopsy principles, staging, chemotherapy protocols, surgical decision-making, targeted therapy, and long-term complications. By the end of this lecture, you will be equipped to recognize, investigate, and manage osteosarcoma in children with confidence. Let us begin. Before we dive into the cases, let us quickly review what this lecture will cover. Our four main learning objectives are: first, to recognize classic and atypical presentations of osteosarcoma in children. Second, to interpret key imaging and histopathology findings. Third, to apply evidence-based diagnostic criteria and staging workup. And fourth, to outline current treatment principles and complication management. The format is 15 case-based multiple-choice questions with detailed illustrated explanations. Let us get started. Question 1. Clinical presentation. A 13-year-old male presents with a 6-week history of progressive pain and swelling in the right distal femur. The pain is worse at night and not relieved by rest. He denies fever or weight loss. His mother notes he has been limping for 2 weeks. What is the most likely diagnosis? Option A, Ewing's sarcoma. Option B, osteosarcoma. Option C, osteoid osteoma. Option D, septic arthritis. The correct answer is option B, osteosarcoma. This case presents the classic picture. The patient is 13 years old, which falls within the peak incidence range of 10 to 20 years. The location is the distal femur, which accounts for approximately 30% of all osteosarcoma cases and is the most common site. Night pain that is progressive and not relieved by rest is a hallmark red flag for malignancy rather than mechanical or infectious causes. The absence of fever makes septic arthritis less likely. On X-ray, you would expect to see the Codman triangle, which represents periosteal elevation and a sunburst pattern of aggressive periosteal reaction, both hallmark radiographic findings of osteosarcoma. Question 2. Pathophysiology. A pathology resident reviews a biopsy from a 14-year-old with a distal femoral mass. The report describes malignant spindle cells producing osteoid matrix directly. The attending asks which genetic alteration is most classically associated with conventional high-grade osteosarcoma. Which of the following gene mutations is most commonly implicated? Option A, RB1 loss and TP53 mutation. Option B, EWSR1, FLI1 fusion. Option C, ETV6, NTRK3 fusion. Option D, ALK rearrangement. The correct answer is option A, RB1 loss and TP53 mutation. Osteosarcoma is the most common primary malignant bone tumor in children and arises from primitive mesenchymal bone-forming cells. The two most important tumor suppressor pathways implicated are the retinoblastoma pathway and the P53 pathway. Loss of the RB1 gene disrupts cell cycle regulation, leading to uncontrolled osteoblast proliferation. This is why children with hereditary retinoblastoma, who carry a germline RB1 mutation, have a significantly elevated lifetime risk of osteosarcoma. TP53 mutation leads to failure of apoptosis and is associated with Li-Fraumeni syndrome, another hereditary cancer predisposition syndrome. Chromosomal instability from these mutations drives the rapid growth and aggressive behavior of this tumor. The EWSR1, FLI1 fusion is the hallmark of Ewing's sarcoma, not osteosarcoma. Question 3. Pathophysiology, histology. A biopsy from a 12-year-old with a proximal tibial mass is examined. The pathologist notes that malignant cells are directly producing osteoid, which is immature bone matrix, without cartilage or fibrous differentiation. This is the defining microscopic feature separating this tumor from others. What histological subtype accounts for approximately 80% of all osteosarcomas in children? Option A, chondroblastic osteosarcoma. Option B, fibroblastic osteosarcoma. Option C, conventional osteoblastic osteosarcoma. Option D, telangiectatic osteosarcoma. The correct answer is option C, conventional osteoblastic osteosarcoma. This subtype accounts for approximately 80% of all osteosarcomas in children and is therefore the classic form you must know. Its defining histological feature is the direct production of osteoid matrix by malignant cells. Under the microscope, you will see malignant osteoblasts, a pink osteoid matrix, highly pleomorphic nuclei, and atypical mitoses. The chondroblastic subtype, accounting for approximately 10%, has a dominant cartilaginous matrix. The fibroblastic subtype, also approximately 10%, shows spindle cells within a fibrostroma. The telangiectatic subtype is rare and is characterized by blood-filled spaces, making it highly lytic on X-ray and sometimes confused with an aneurysmal bone cyst. Question 4. Clinical presentation, symptoms. A 15-year-old tall male presents to your clinic with a 2-month history of right knee swelling and dull aching pain. His mother mentions the pain began after a minor sports injury. Physical examination reveals a firm, non-tender bony mass at the distal femur. He is afebrile and his complete blood count is normal. Which of the following features most strongly points away from osteosarcoma in this patient? Option A. Location at the metaphysis of a long bone. Option B. Afebrile with normal complete blood count. Option C. Age 15 with rapid growth spurt history. Option D. Onset associated with minor trauma. The correct answer is option D. Onset associated with minor trauma. This is a classic exam trap. Trauma does not cause osteosarcoma. When a patient says their pain began after an injury, trauma simply draws attention to a pre-existing lesion that was already there. The classic presentation of osteosarcoma is an adolescent with pain and swelling in the metaphysis of a long bone, particularly the distal femur, proximal tibia, or proximal humerus, with night pain, firm swelling, and a rapid growth phase history. Being afebrile with a normal complete blood count helps exclude infection and leukemia, but does not rule out a tumor. Age 15 and rapid growth are actually risk factors for osteosarcoma. The key clinical pearl is a trauma history is coincidental, and persistent bone pain must always be investigated regardless of any preceding injury. Question 5. Clinical presentation, physical examination findings. A 13-year-old girl presents with left shoulder pain and limited range of motion for 8 weeks. On examination, a firm, fixed, non-pulsatile mass is palpated at the proximal humerus. The overlying skin is warm. No axillary lymphadenopathy is noted. She is afebrile. An X-ray is ordered. Which of the following examination findings, if present, would most suggest advanced local osteosarcoma? Option A. Pathological fracture through the mass. Option B. Axillary lymphadenopathy. Option C. Pitting edema of the limb. Option D. Erythema migrans skin rash. The correct answer is option A. Pathological fracture through the mass. A pathological fracture is defined as a fracture occurring through diseased bone with minimal or no trauma. In osteosarcoma, it occurs in approximately 5 to 10% of patients at presentation and signifies severe cortical destruction, which indicates poor local control and complicates surgical planning. The presence of a pathological fracture may require upgrading from limb salvage to amputation. An important teaching point is that lymph node metastasis is rare in osteosarcoma, unlike carcinomas, so axillary lymphadenopathy would not be a typical feature. Pitting edema suggests venous or lymphatic obstruction and is not specific. An erythema migrans rash would suggest Lyme disease, an entirely different diagnosis. Question 6. Investigations, imaging. A 14-year-old male with 6 weeks of right femur pain and swelling undergoes a plain radiograph. The radiologist describes a mixed lytic and sclerotic lesion at the distal femoral metaphysis with periosteal reaction and a soft tissue mass. An orthopedic oncologist orders additional imaging. What is the best next imaging modality to assess local tumor extent and guide surgical planning? Option A. Technetium 99N bone scan. Option B. Magnetic resonance imaging of the affected extremity. Option C. Computed tomography chest with contrast. Option D. Positron emission tomography combined with computed tomography scan. The correct answer is option B. Magnetic resonance imaging of the affected extremity. Magnetic resonance imaging is the gold standard for local staging of osteosarcoma. It provides the most detailed information about intramedullary tumor extent, marrow involvement, neurovascular proximity, soft tissue extension, skip lesions within the same bone, and surgical margin planning. On T1 sequences, the tumor appears as a low-signal metadiaphyseal mass, while T2 and STIR sequences reveal high-signal marrow edema and soft tissue extension. Plain X-ray remains the initial screening tool and shows the classic Codman triangle and sunburst periosteal reaction. Computed tomography chest is ordered specifically for pulmonary metastases, which are the most common site of distant spread. Bone scan is used for detecting skip lesions and polyostotic disease. Positron emission tomography combined with computed tomography serves as a systemic staging adjunct. Question 7. Investigations, labs, and biomarkers. A 12-year-old with biopsy-confirmed osteosarcoma of the proximal tibia has the following labs: Complete blood count normal. Erythrocyte sedimentation rate 45 mm per hour. C-reactive protein 12 mg per liter. Alkaline phosphatase 420 units per liter, which is high. And lactate dehydrogenase 380 units per liter, which is also high. Which combination of laboratory values carries the worst prognostic implication in pediatric osteosarcoma? Option A, elevated erythrocyte sedimentation rate and elevated C-reactive protein. Option B, leukocytosis and thrombocytosis. Option C, low hemoglobin and elevated ferritin. Option D, elevated alkaline phosphatase and elevated lactate dehydrogenase. The correct answer is option D, elevated alkaline phosphatase and elevated lactate dehydrogenase. These two enzymes are the most prognostically significant laboratory markers in pediatric osteosarcoma. Alkaline phosphatase reflects osteoblastic activity, and an elevated level correlates with high tumor burden and aggressive bone matrix production. Lactate dehydrogenase correlates with tumor necrosis rate and overall proliferation. Both elevated alkaline phosphatase and elevated lactate dehydrogenase have been independently associated with poor survival in multiple studies. They are also used to monitor response to chemotherapy during treatment. Elevated erythrocyte sedimentation rate and C-reactive protein are nonspecific inflammatory markers and are less prognostically relevant. The complete laboratory workup includes complete blood count with differential to exclude leukemia, a metabolic panel, alkaline phosphatase, and lactate dehydrogenase. Question 8. Investigations, biopsy, and staging. A 13-year-old with a suspected osteosarcoma of the distal femur undergoes staging workup. Imaging shows an 8 cm metaphyseal mass with cortical destruction and a 2 cm soft tissue component. Computed tomography chest shows no pulmonary nodules. Bone skin shows no skip lesions. The team discusses the definitive biopsy approach. Which biopsy technique and approach principle is most critical in suspected osteosarcoma to avoid compromising limb salvage? Option A, excisional biopsy through the most accessible approach. Option B, fine needle aspiration from the soft tissue component. Option C, core needle biopsy along the planned surgical incision axis. Option D, open incisional biopsy with wide margins. The correct answer is option C, core needle biopsy along the planned surgical incision axis. Biopsy technique in osteosarcoma is one of the most critical oncological decisions and must follow strict principles to preserve limb salvage options. The definitive surgical incision must be planned first, and the biopsy must be performed along that same axis. This is because the biopsy tract becomes contaminated with tumor cells and must be excised and blocked during the definitive resection. Core needle biopsy is preferred over open biopsy because it causes less tissue contamination. The approach must never cross compartments, as tumor seeding of an additional compartment would require a more extensive resection or even amputation. The specimen should be sent for frozen section during the procedure to confirm diagnostic adequacy. An incorrect biopsy approach is considered the single most preventable cause of unnecessary amputation in osteosarcoma management. Question 9. Staging and classification. A 14-year-old male is diagnosed with osteosarcoma of the proximal humerus. Magnetic resonance imaging shows the tumor confined within the bone with no soft tissue extension. Computed tomography chest reveals 2 8 mm pulmonary nodules. Bone scan is negative for skip lesions. The pediatric oncologist stages the disease. According to the Eniking staging system, what stage is this patient's disease? Option A, stage 3. Option B, stage 2A. Option C, stage 2B. Option D, stage 1B. The correct answer is option A, stage 3. The Eniking staging system classifies musculoskeletal tumors based on 3 parameters: tumor grade, compartmental extent, and presence of metastasis. Stage 1A is low grade, intracompartmental, no metastasis. Stage 1B is low grade, extracompartmental, no metastasis. Stage 2A is high grade, intracompartmental, no metastasis. Stage 2B is high grade, extracompartmental, no metastasis. Stage 3 is any grade, any compartment, with distant metastasis. In this case, the pulmonary nodules represent distant metastases, making this stage 3 regardless of local tumor extent. Approximately 20% of osteosarcoma patients present with detectable metastases at diagnosis. The lungs are the most common metastatic site, accounting for over 90% of distant spread. Skip lesions within the same bone also qualify as stage 3 disease. Question 10. Treatment, chemotherapy. A 13-year-old girl with high-grade conventional osteosarcoma of the distal femur, stage 2B, begins treatment. Her oncologist explains the standard treatment protocol, which involves chemotherapy both before and after surgery. Which chemotherapy regimen is considered the standard backbone for pediatric osteosarcoma treatment? Option A, vincristine plus actinomycin plus cyclophosphamide. Option B, high-dose methotrexate plus doxorubicin plus cisplatin, the MAP regimen. Option C, ifosfamide plus etoposide. Option D, carboplatin plus gemcitabine. The correct answer is option B, high-dose methotrexate plus doxorubicin plus cisplatin, known as the MAP protocol. This is the standard of care regimen for the Children's Oncology Group and URAMO's international guidelines. Treatment follows a three-phase approach. Phase 1 is neoadjuvant chemotherapy using the MAP regimen administered over approximately 9 to 10 weeks. This is followed by wide surgical resection, during which the histological necrosis response is assessed using Huvo's grading. A good response is defined as 90% or more tumor necrosis, and in this case MAP is continued as adjuvant therapy. A poor response, meaning less than 90% necrosis, may prompt the addition of ifosfamide and etoposide to the adjuvant phase. The total treatment duration is approximately 29 to 34 weeks. Vincristine plus actinomycin plus cyclophosphamide is the standard backbone for Ewing sarcoma, not osteosarcoma. Question 11. Treatment, surgery. A 14-year-old male with distal femoral osteosarcoma completes neoadjuvant chemotherapy. Magnetic resonance imaging shows good tumor response with no neurovascular encasement. The orthopedic oncologist discusses surgical options with the family, noting an excellent chemotherapy response with over 90% tumor necrosis on the post-chemotherapy biopsy. What is the preferred surgical approach for this patient given these findings? Option A, above-knee amputation. Option B, rotationplasty only. Option C, curettage with bone cement packing. Option D, limb salvage with endoprosthetic reconstruction. The correct answer is option D, limb salvage with endoprosthetic reconstruction. Limb salvage is achievable in approximately 90% of osteosarcoma cases when the appropriate criteria are met. These criteria include an adequate chemotherapy response, no neurovascular encasement, adequate bone stock, and growth plate considerations in younger patients. When criteria are met, limb salvage with an endoprosthesis, also called an expandable or modular prosthesis in growing children, offers equivalent survival outcomes compared to amputation with the benefit of preserved limb function. If neurovascular involvement is present, amputation or rotationplasty becomes necessary. Rotationplasty is a specialized procedure where the lower leg is rotated 180 degrees and reattached, so the ankle functions as a knee joint, and it is particularly considered in very young children under 8 years of age. Curettage alone is never appropriate for high-grade malignant bone tumors as it leaves residual disease. Question 12. Treatment, radiation, and targeted therapy. A 15-year-old with osteosarcoma of the proximal femur has progressed after 2 lines of chemotherapy. His oncologist reviews options. The team discusses the limited role of radiation in osteosarcoma and considers newer targeted agents. The tumor is tested for mTOR pathway activation, which targeted agent has shown activity in relapsed or refractory osteosarcoma and is currently under investigation. Option A, imatinib, a BCR-ABL inhibitor. Option B, rituximab, an anti-CD20 antibody. Option C, sorafenib, a multi-kinase inhibitor. Option D, trastuzumab, an anti-HER2 antibody. The correct answer is option C, sorafenib, a multi-kinase inhibitor. Osteosarcoma is inherently radioresistant due to its protective dense bone matrix, so radiation has a very limited role and is used only for palliation or in unresectable, symptomatic disease. Radiation is rarely curative. In the realm of targeted therapy, sorafenib, which inhibits vascular endothelial growth factor receptor, platelet-derived growth factor receptor, and RAF kinases, has shown approximately 29% progression-free survival in relapsed disease in a phase 2 trial. Regorafenib has also shown activity in the REGABONE trial. Somatolizumab, which targets the mTOR pathway, is currently under investigation. Cabozantinib, targeting MET and vascular endothelial growth factor receptor, is in active studies. Importantly, no targeted agent has yet received regulatory approval specifically for osteosarcoma. Immunotherapy with pembrolizumab is also under clinical trial investigation. Question 13. Complications and associations. A 10-year-old girl completes treatment for proximal tibial osteosarcoma with limb salvage surgery and MAP chemotherapy. She is now in remission at 2 years follow-up. Her parents ask about long-term risks. She received a cumulative doxorubicin dose of 375 milligrams per meter squared. Annual echocardiograms have been ordered. Which late effect is most directly related to doxorubicin exposure in this patient? Option A, cardiomyopathy. Option B, peripheral neuropathy. Option C, nephrotoxicity with Fanconi syndrome. Option D, ototoxicity. The correct answer is option A, cardiomyopathy, which is the primary dose-dependent late effect of doxorubicin. This patient received a cumulative doxorubicin dose of 375 milligrams per meter squared, which exceeds the 300 milligrams per meter squared threshold associated with significantly elevated cardiac risk. Doxorubicin causes cardiomyopathy through free radical damage to cardiomyocytes, which is why annual echocardiogram and electrocardiogram monitoring is mandatory. The other drugs in the MAP protocol also carry specific late effects. Cisplatin is associated with ototoxicity, nephrotoxicity, and hypomagnesemia, requiring annual audiology, renal function, and magnesium level monitoring. High-dose methotrexate can cause hepatotoxicity and nephrotoxicity, monitored with liver function tests and renal panels. Ifosfamide, used in poor responders, causes Fanconi syndrome and hemorrhagic cystitis. Limb salvage surgery carries its own long-term risks, including prosthesis failure and limb length discrepancy, requiring orthopedic follow-up and growth monitoring. We would like to take a moment to tell you about our Pediatric Case Review community on Patreon. If these lectures are helping you learn, you will find even more value inside the community. All videos are organized by system, so you can access every lecture in one structured, easy-to-navigate library and find exactly what you need instantly. All presentation slides are available as photos, so you can read through them and practice all multiple-choice questions anytime, anywhere, at your own pace. You will also be joining a growing community of pediatric learners where you can study together, discuss cases, and level up your clinical knowledge. If you are interested in joining and want to know all the details about how to subscribe, simply comment below in this post, and we will personally message you with everything you need to know. And that brings us to the end of today's lecture on osteosarcoma in children. Let us review the key takeaways. Osteosarcoma is the most common primary bone malignancy in children with a peak incidence between 10 and 20 years of age. The most common locations are the distal femur, proximal tibia, and proximal humerus, all with a metaphyseal predilection. The osteoblastic subtype accounts for approximately 80% of cases, and direct malignant osteoid production is the defining diagnostic feature. Magnetic resonance imaging is essential for local staging, and computed tomography chest is required for detection of pulmonary metastases. Biopsy must always be performed along the planned surgical incision axis to protect limb salvage. The MAP chemotherapy protocol combined with wide surgical resection is the standard of care, with limb salvage achievable in approximately 90% of cases. Long-term monitoring must include cardiac, auditory, and renal function surveillance throughout survivorship. If you found this lecture helpful, please follow the Pediatric Case Review channel for more case-based lectures. If you have any questions, drop them in the comments below. We read every single one. Thank you for watching.